Testing 1, 2, testing 1, 2. Okay. Okay, everybody, welcome. We start in about 12 minutes.
Hello, John.
Hello,
How are you?
good. Who's this?
Mohammed Helmi. Could you please allow me to join the panelists? I will moderate the session.
Okay, this is Mohammed, right? Yeah, okay, let me try to get you in here. Here's Michael. You can hear me, right, Mohammed? Hello, Michael.
Hey, John. Hey, Ron.
How you doing?
Good.
Okay, I got your slides. So you want me to share the slides?
Oh, no, I can. I don't know why she sent them to you, but
Oh, that was nice. Yeah, I'm glad you said that, Mike, because I'm really bad with doing that stuff. I screw it up all the time.
yeah. No, don't worry. I like to run my own slides almost no matter what.
Yeah. We're gonna have a good Chinese car. I know that for sure.
Yeah.
It's kind of tough in this part of the world. It's like work time, Friday morning. So it might be tough to get neurosurgeons from this part of the world.
Yeah, but I mean, if it's translated mainly into Chinese, I imagine most people are gonna be in Asia.
Yeah. And we should get the Indian crowd, India, and of course, hopefully Australia. We have our first Afghanistani neurosurgeon.
No, that's a new era.
Yeah, it's widespread. Let me introduce you to him. Ahmed, how you doing?
Alles
Hello,
gut.
how are you, Professor John? Hello, Michelle.
This is I'd like you to meet Michael personally,
Yes,
the speaker.
Yeah.
Hey, how are you?
yeah. Hello, greeting. I'm Dr. Pirzad from Afghanistan. Ahmad Fawad Pirzad.
Yeah, good to meet you.
Okay,
Okay,
welcome.
thank you.
Yeah,
Thank you.
you can ask a lot of questions, Ahmad, after his presentation. Lots
Yes,
of them
okay.
if you want.
Okay.
And we welcome your presence.
Thank you very much. Thank you for your support and for your nice word every time. Yeah, okay.
Okay, thank you.
Thank you.
Okay, about 7 minutes, Michael.
Okay, we still have time. Yeah.
Yeah, we have 7 minutes.
Yes.
Mohammed, you're not in yet?
Yes.
I'm trying to, are you in yet? I haven't, oh, there you go, you got in. You got in there, Mohammed?
Yes.
Salam
Oh, okay,
alaikum.
you don't have a camera?
I will open it. Just give me a minute.
Assalamu alaikum.
Oh,
Salam.
I see you worked with Ben.
Yes. I'm his
Mhm.
master degree student.
Yeah. Oh, how you doing? I'd like you to
Oh.
meet Michael before we start. Michael.
Hi, how are you?
This is Mohammed.
Michael.
Where
Mohammed, are
you
you
at,
located?
Mohammed? Where you at, Mohammed?
And now I'm in Egypt. I will join Professor Benshu maybe next month in Shanghai.
Oh, okay.
Hi, Professor Mike. It's very honored to contact with you.
Oh, thank you. Good to meet you guys too.
Thank you.
Where you at, Michael? Australia now?
Yeah, I'm in Sydney for once.
Sydney?
Dr. Muhammad. I'm Dr. Ahmad Fawad Pirzad from Afghanistan.
Hi, nice to meet you.
Okay, okay, thank you. We know Dr. Nasser Al-Ghamdu.
Yes, he's a great friend of me.
Oh, yeah. Professor Nasser is the chief of education committee of WFNS, and he have a lot of webinars for young neurosurgeons.
Exactly. I co-organized some webinars with him, and he's the chairman of the Egyptian Society of Neurological Surgeons.
Yeah. It's
Yeah.
kind man, yeah.
Yeah. I will meet him tomorrow, you know. I have an
Oh,
appointment with him tomorrow.
okay. Please say my regards and salams to him.
I will. Thank you.
Okay, thank you. Dr.
Should be
Danesh,
starting in about 4 minutes. Ben still isn't here. Waiting, Dr. Ben.
Yes, Professor
Mohammed,
Ben,
where'd you work with Dr. Ben?
actually, I worked with him since 2019, but unfortunately, because of the COVID, I left China in 2020, you know.
Oh, okay.
So now it's the time to go back. I finally got the visa.
Oh, okay.
And hopefully they start normalizing like the rest of the world has. But
Exactly. We still have some quarantine, like 7+3 days, but
oh,
it's fine.
I know
At
all
least we
about it.
can.
I'm going there in November.
Exactly. That's true. But they will ease it more, I think, in the near future.
Yeah, hopefully once Xi Jinping gets his re-election thing done, then we can all go back to normal and go to China and like everyone open it up like everywhere else, which we'll be back to normal.
Exactly.
There's other restrictions, Mike, in Australia with traveling now, or is it pretty open?
No, completely open.
Completely open.
I've been almost everywhere that was Adele lockdown, Europe, US, I haven't been to Canada, but short of that. And there's no one has any restrictions anymore.
But it was hard to get to China for a while, right?
Oh, China's still fully locked down, but I mean, like it's not locked down, but they're still doing lockdowns, and you
It's
still
a 3-week period of what do they call it?
1 week. It's going down to 1
Oh,
week.
1 week now. Okay.
Yeah, otherwise you'd have to basically be going back home to put up with that. But it's at a week, so a lot of us are kind of like, well, if you got to go for a while, then just set up a thing and stuff out the quarantine. So I'm going in November.
Okay. We hope to see you there.
I'm almost 100% going to be in Shanghai.
Wow, that's
Yeah.
great.
Yeah, I'll be there for almost a month.
Great.
That's the headquarters of Connectomics.
We've always been our company's always had a big office in China. So we have an office in Shenzhen. We work with a lot of Chinese groups. The software is available there, et cetera, et cetera. So we haven't been able to go over there and sell, but we're going to go there and do a hard launch here pretty soon. And I'm going to go around and do what I do in the US, which is talk to a lot of people.
Okay.
You're welcome to come to Huashan Hospital.
Yeah, I've actually we're working with someone at Huashan, but yeah, absolutely we'll go.
Yeah.
But obviously it's one of the top places. So
Greetings, Ben.
Hi,
Welcome.
hi, John. Hi. I'm just
Hi.
arrived. Hi, Michael. Nice to see you.
yeah,
I just
Ben, you don't have to apologize. You're actually on time.
Yeah.
thank you.
Hello, Professor Ben.
Hi.
How are you?
Ahmed from Afghanistan.
Yeah. Ahmed.
I think you met him before. You met him.
Mhm.
We have a Colombian, or so we'll just take her.
John,
Yes.
tonight, Mohammed Halim will be the host
Oh, okay.
for
That's
this
great.
series. Yeah.
Oh, okay. Mohammed, so I'll just, you want me to
Hear me.
introduce you, Mohammed?
Sorry?
I'll introduce you and then you take it away.
It's okay.
Is that okay?
Yeah, it's okay.
Okay.
I can take the introduction part.
Okay, yeah. Well, okay, I'll go. So you want to host everything. Well, I prefer, let me just introduce you. I'll say I'm John Bennett from Neurosurgical TV. I'd like to turn the program over to Mohammed Helmi.
Yeah.
Neurosurgery, you're a neurosurgery resident, right?
I'm a master's degree candidate in Huashan Hospital, Fudan University.
Okay, so you're a neurosurgeon now or a neurosurgery resident?
Actually, a resident.
Resident, okay.
Yes.
It's a little different, John, in most of the world where it's actually a degree. Residency is actually a degree. So it's like a master's is basically the equivalent of residency. In the US, we don't give it you don't get a degree. You just get to leave and go make
Exactly.
money.
Oh, okay.
Yes.
Okay, you ready to go, Mohammed? Let me start, okay?
Okay.
Hold
Okay.
on. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett with Neurosurgical TV. We have another Chinese, actually this is a new series. This is not a regular thing, but it will be for 5 weeks. Mike's gonna have 5 different lectures. And let me turn it over to Mohammed Salmi. He's a resident and he's going to act as host today. So take it away, Mohammed.
Thank you, John. So good morning, good afternoon, good evening to all our dear neurosurgeons, wherever you are. And thank you for joining us. It's a privilege to me to introduce Professor Michael Sughrue. Professor Mike finished his residency in UCSF. Later, he joined the faculty of Oklahoma University and served there as a director of the Brain Tumor Center. After staying there for 7 years, where he developed his interest in connectomics and white matter anatomy of the brain. Since that time, he authored more than 250 scientific publications and 4 textbooks. Professor Mike moved later to Sydney, where he co-founded Omniscient Neurotechnology Company. Dear colleagues, we are highly welcoming to any questions during or after the webinar. So please, if you have any question, you can leave it in Q&A box or raise your hand, and we will give you the mic. Professor Sughrue, please share your screen and go ahead, please.
Well, thanks for everyone for coming. As you pointed out, this is the beginning of a 5-part course. This is now roughly my 100th time teaching a course on this. So we spent a lot of time thinking about what to talk about, what people need to know, and it's always a little different every time. This is going to be aimed really at a surgical angle, and what we're going to be talking about is the anatomy of brain networks and the connectome. So I'm going to make sure we really, if you gain nothing else out of this course, what we're really trying to get is that you know the anatomy of networks, what these networks do, and as a result, over the next 5 courses, we're going to talk about networks a lot. And the reason for this is that realistically, as clinicians, we haven't really used this term, but it's been deeply entrenched in neuroscience for over a decade. The evidence that these things exist is extensive. The organizing principle of the brain is extensive, and it's really time that we start beginning to think in terms of networks and how do we use them? How do we make better decisions in the operating room? And also, how do we leverage existing technologies to get better outcomes? So today's lecture is just going to be getting everyone on the using the terms correctly, talking about the anatomy of networks, giving a basic preview of what we're going to be covering over the next 4 weeks, and showing some of the ideas, technologies, and methods that we've done over the last decade, trying to leverage and understand brain networks to do better surgery. So ultimately, we as neurosurgeons, when we cut something out of the brain, now gliomas are the most obvious one, but pretty much anything, from an AVM, cav mal, whatever, at some point in the operation, you are cutting brain tissue. It may not be a lot, but in many cases, when we're talking about gliomas, we're putting a large hole in the brain where there used to be a lobe. And we know that gliomas infiltrate the brain. We know that they grow between neurons, and they even grow into synapses. So while you might be able to stay in the tumor sometimes, there's, by definition, at some point, you're up against brain. And so when we begin to really try to master these tumors, when people first started to go in and try to remove these, people got neurological deficits in speech and motor. And over the last 25 to 30 years, many, many people have contributed to figuring out techniques for reducing that problem. And we're pretty good at that. What we're not good at is everything else. So when we start going into vision, people have done a little bit with that. If you get into cognitive function, alertness, avoiding mental illness, our track record is poor. And this isn't because we don't care, though there are probably some people who would just remove the tumor almost no matter what. Most of us would like to have better outcomes in that domain. We'd like to have patients be as normal as possible given the problem they came in the door with. It's that we don't know the anatomy. And it isn't that people haven't thought of it. We know that there's cognitive function in the frontal lobe and the parietal lobe, the temporal lobe, et cetera. But when we start getting into surgery, we have to make very, very fine distinctions. We have to say, I'm cutting here and not here. And it is clear to anybody who's thought about this that we lack the tools and understanding to do this, to really make those precise distinctions and consistently get the same result. And so ultimately, when we start talking about trade-offs, and particularly in gliomas, the trade-off is what we're doing, then we don't really make these decisions with all of the facts. So when we start talking about the term oncofunctional balance, this refers to the fact that the more of a tumor you remove, the better the outcome is with gliomas. But it is pretty much almost never a cure. Maybe some people live a long time, but we know that almost everyone, the tumor comes back at some point. So we're not curing these patients. So there is a line when the additional benefit that we get, how many cancer cells we're removing, how much we're actually changing the natural history of the disease, starts to decline, and the risk of problems start to go up. The more you go into brain that isn't, a tumor, the more likely you are to get problems. Now, we all kind of grasp this. People have talked about this a long time, and we all know that pushing the boundaries to the absolute maximum to make the scan look normal sometimes isn't the right answer for patients. Having said that, we also have to think realistically about what kind of patient are we treating. And so if you look at the patient on the left, if I told you that leaving half the tumor in here, and I was doing that because ultimately I wanted to avoid subtle cognitive problems, that's insane, right? If we don't control this tumor, the patient's gonna be dead, usually pretty quick. So what we want to do is leave the patient in the best situation we can, given that there's a massive glioblastoma in the parietal lobe. On the other hand, being aggressive with the patient on the right to get 1% more of the tumor is also not a good idea. So while you may not necessarily do just a biopsy, there always is a point where we say, well, the amount of tumor we get for the problems that we cause isn't a good trade-off for this patient. And so in order to really make the oncofunctional decision correctly, we have to understand the oncology, which we do, but a little bit. We don't really know how these tumors are going to behave, but we have some idea. With mutations like IDH1, we can make a better guess than we could 20 years ago. But the second thing about it is we don't know the function other than the motor cortex, things like this that have been known for a long time. And so since I was a resident at UCSF, I've always had an interest in how do we minimize cognitive problems. And it was just being a resident and seeing patients who look fine, but were not fine. They don't go back to normal. They have family emotional issues. And it isn't that because people are doing bad surgery, it's that we didn't know what was in there. And part of the reason is that we spent a lot of time talking about eloquent brain regions, as if the rest of the brain is a decoration that's sucking CSF. And we know that everything isn't eloquent. We know that that's not reality either. So we know that a lot of the brain we can cut and the patient doesn't get an obvious deficit. So what we're really talking about is not that there's this part of the brain where it doesn't matter. That it's what can the patient tolerate and what can they not? What's a good trade-off? What's a bad trade-off? And people have begun talking like this because, again, as we've started to get speech and motor preservation rates in the 90%, which most people doing mapping are in that range, then what's the next step? How do we do better than that? And people have started to think about taking a stimulator and putting in the brain while you do more complicated cognitive tasks. And 10 years ago, I got very interested in this because, again, I've thought about how do we improve cognitive function for a long time. I think the problem with it is that I became convinced that this wasn't going to be the solution to the problem. And there's a couple reasons for it. The first is when I stimulate a part of the brain that does higher cognition, I'm assuming that there's one part of the brain that when I disrupt it, it's going to throw the whole system off in a way that I'm going to immediately see that, just like speech arrest. When you stimulate certain parts around the Broca's area, you get a speech arrest, usually in the face motor regions. But the problem with it is that higher cognition isn't always like that. And so that's a problem. And the second thing about it is when we do intraoperative testing, can we really meaningfully test working memory or how someone's going to behave in the real world, or can they go back to work in the operating room? I mean, people have done some creative stuff. I've done some creative stuff. I've even been on TV doing some creative stuff in the operating room. But is that really telling us something? Because ultimately, if I see something in one of those things, but I don't even know why that's disruptive, am I going to leave it in tumor in the head? That's a tough choice. I want to really know why I'm putting the line there and not further in. Why am I leaving that tumor behind? Because it has consequences. And ultimately, if we don't know the anatomy of what we're trying to save, we're very unlikely to consistently save it. The way to think about it is this. If I didn't know where the facial nerve was, it's unlikely that I'm going to save it removing an acoustic neuroma. The mental picture that we take in the operating room is our most important tool. And we don't have a clue what we're trying to save. So how are we going to save it? So ultimately, what I'm going to try to show you is that having a better understanding of how the brain works and knowing what we're in there to actually do is going to improve your chances of getting good outcomes. And so there's different ways to get at this. You can see that there's some concepts that we've talked about. I don't have time to go into all of this. Some of this we'll talk about a little bit later. Some of it is in different lectures. And if you look at number 4, the concept of changing the connectome, there's an entire lecture on that, and we'll get to this. But what we're going to talk about a lot is brain networks. So I'm going to keep going over and over that. And basically, while every part of the brain is part of at least one network, some networks and some parts of networks are probably more important than others because they're the core. They're the part of the network that tells the rest of the network what to do. And there's a lot of evidence that saving the core of a network is a good idea. Now, one of the things about it, when we first started teaching this course, which was 2015, if I remember right, 2015, 2016, the first time I taught one of these courses. And the thing that really I found was that a lot of people think about tractography or whatever as how do I plan a trajectory to the tumor? And that's a good idea, but it isn't everything. So if you look at that tumor in the thalamus, that's the entire question of how do you get to this thing safely? What's the best angle? The patient on the patient on the left doesn't have that as a question. What really you have to say is, where is the function around this tumor and how do I disconnect the tumor from the rest of the brain? So when we start looking at a tumor like this, so this is a splenial butterfly glioma. What has been known for a long time is if you go charging into this thing and you try to remove it and you don't really preserve the normal anatomy, then it is very likely the patient is going to have serious cognitive problems if they don't already have it. And by that I mean having really very poor, if any, short-term memory transfer. They just don't, like HM, the person who had bilateral hippocampectomies. But the question is why? Because the splenium does not really connect areas that are known for memory. It connects visual areas. So why is the corpus callosum important if there's a tumor in it, but we can cut it in an epilepsy case without consequence, or a transcallosal? And the reason for it is that it's not just in the corpus callosum. There's anatomy around that. And in order to remove a tumor like this appropriately, you have to disconnect it in multiple places. So let me walk you through the concept here. So you have this butterfly tumor. You see that there's a portion in the corpus callosum, but then if you look on the bottom row or even in the left, there's a big dumbbell part, and that's the part in the parietal lobe. That's the dangerous part. It's not the callosum. The callosum is irrelevant. Now, it's the cingulate gyrus. It's the part that's around the motor cortex. It's the part that's around the language system. And most importantly, most notably at least, is that it does a 270-degree bend around the DMN, which stands for default mode network. This is the most important cognitive network in the brain. It's been extensively documented. And again, we have repeatedly found in multiple studies now that preserving the DMN seems to be a good idea. And this tumor is tucked around it. It's because the corpus callosum wraps around both cingulate gyri. And so when you work on this tumor, in order to remove it or do anything with it, even debulk it, you really have to think about it as making a series of cuts. So you see there's cuts with the cingulate, there's cuts with the corpus callosum and the falx, there's a cut with the motor cortex, there's a cut with the language system. And so ultimately, in order to safely remove this, you have to remove this, you have to basically make a series of cuts. Now, in the past, people have taken a CUSA and just removed it or whatever. It's not so important how you do it. I try to take as much out on block as possible. I find I get better resections, I get better results. There's a lot of reasons I try to take it out as I do the disconnections first. But it doesn't really matter what you do. It matters that the concept of where you stop and where you put your maneuvers are in the right location. Okay, so that's the most important thing. And also remember that while these cuts I'm showing you in 2 dimensions, they're 3-dimensional cuts, and they may need to vary. They may need to be kind of jagged in some cases. And ultimately, doing the cut correctly for the first millimeter and then veering into the corticospinal tract doesn't really count. You have to actually get the entire cut correctly. And there are very specific ways you can do. One of the most dangerous things when you're making a disconnection is actually you angle. You don't remain orthogonal to the sulcus. You actually change your angle when you get subsulcal. And that's how you get into things that are connecting parts of the brain going somewhere else. And so when we think about white matter, the area that's above the sulcus, the white matter fibers are terminating in that gyrus. So while you can cause a deficit, you're not going to disconnect something that's connecting two areas that you're not operating in. And that's really where you rack up the serious morbidity, is down below the sulcus. I tell my residents, I call it tiger country, because there's no anatomy. It's really dangerous. And so ultimately, when we make these cuts, we need to maintain orthogonality. We need to maintain three-dimensional orientation, and we need to make sure that we're only cutting out the part of the brain we think we're cutting out, ideally the tumor. Those kind of very simple things are critical for minimizing accidents. And as a result, thinking about in terms of cuts makes you safer. So I wrote an entire book about this. If anyone wants, you can purchase it. And I'll talk about it a lot in this course, because it doesn't mean that these are the only way to do brain surgery, but it basically is a way to visualize where the risk is and how do you minimize that risk. And so ultimately, one of the problems with how we learned how to do brain surgery, at least how I learned, and I thought I trained it with great people who did the best thing possible at the time, was that we would say that there were these eloquent parts of the brain and you want to be the non-eloquent parts, stay in the tumor and the corticospinal tract. That was a bad thing, don't cut that. But other than that, the rest of the brain is fair game, do what you had to do. And again, sometimes that works and patients go home and they do great. But if you go really spend your time talking to people, or you look at any study that's looked at cognitive function, these people aren't really as normal as we think. And if you talk to families, they'll all tell you this, but oftentimes they don't tell you that spontaneously, sometimes they do. So what we have to think about is that while it seems comforting to some degree that we don't see our anatomy, we're cutting next to the networks and there's anatomy there, it's just all wrapped in. So if you think about cutting a white matter fiber that's connecting two critical parts of the brain, it's not functionally any different than cutting the optic nerve. It's the same type of tissue. It's doing the same kind of thing. It's connecting the retina, which is part of the brain, to the medial geniculate nucleus. Cutting the optic tracts, it's just a different continuation of it. While there's some differences in it, it's not radically different. But we would think about cutting the optic nerve as heretical, but we cut the arcuate all the time, at least in the way we used to do surgery. And ultimately, we also have to throw away the idea that there's parts of the brain that don't do anything. That's obviously not true. Everything is doing something. And so just because we don't know it doesn't mean it's not there. And ultimately, when we think about the brain in terms of evolution, we know that the brain didn't evolve CSF sponges. It's always doing something, okay? The question is, what can we get away with? That's what we have to think. What's redundancy? How do we leave patients in a way that even if they have a deficit, that is recoverable or we can recover it? But the idea, what we need to do is stop lying to ourselves and say that there's parts of the brain that don't do anything. That's just not true. So what we need to think about when we plan a tumor surgery is, how do we separate the tumor from the brain with as few problems as possible? And I define this in what I call the 3 Ds: define, divide, and destroy, okay? Now, I can't claim the concept. The concept is actually a Hugh Defoe concept, but I think it's a really solid way to think about brain surgery. So define is to identify the anatomy, the angle, what are the cortical regions doing, even in the sulcus, and really having an idea about what are the angles and planes we need to do to remove the tumor correctly. And it's worth spending some time thinking about it before we just charge on into the brain. The more experience you get, the faster that goes, but it takes me a couple minutes. You don't have to spend 3 hours, but you need to sit there and make a conscious effort to know what sulcus you're entering, what does that part of the brain do, et cetera. The division is the key part, because that defines what's going to go and what's going to stay. And most of the complications, in my experience, in glioma surgery or tumor surgery happen during some kind of thing where you're making a cut or trajectory through the brain. That's where a lot of the morbidity happens. Once you've separated and disconnected the tumor from the brain, it is now pure microsurgery. This is like a meningioma or acoustic neuroma or something. You've changed the operation. Just like if you've ever done a petroclival meningioma, disconnecting it from the tentorium and the skull base is critical, and making everything into one little nice, neat space is critical for seeing everything and finding arteries and not injuring arteries, etc. Because injuring arteries is a great way to cause a lot of deficits very easily. And so what you find with a lot of the complications of glioma surgery is that we don't treat it the same way we treat acoustic neuroma surgery. We go in, we suck the tumor out with some big suction. And of course, if you do that, you're going to have more morbidity than if you take the operation just as serious as you take any other operation. But just because the anatomy is not visible doesn't mean we should use bad technique. Now, the other thing you have to think about, one of the things about interaxial surgery is that people have often kind of viewed it, as simpler than skull-based surgery. And in some ways it is, in some ways it's not. So what I can say is that the chance that you're going to have a catastrophe in skull-based surgery is substantially higher. So if you look at the arteries you have here, it's pretty hard to injure the carotid in a glioma surgery. So it's pretty hard to get completely lost or think you removed the tumor, but you removed a tiny bit of it. All of those things are things that happen if you're not an experienced skull-based surgeon. And if you have people who are inexperienced interaxial surgeons, they get a few deficits, but maybe they would have got that if they were experienced. They move less of the tumor, et cetera, but they don't have disasters. And so people oftentimes persist doing the surgeries inside the brain than outside the brain. Now, skull-based surgery is difficult, and we all know that it takes training to understand what you're looking at and what to do and how to get yourself out of trouble. But there's one advantage that skull-based surgery has that interaxial tumors do not have, and that is that the anatomy is visible and we know all of it. Okay, so you look at the anatomy there's a lot of it, but it's a finite number of things. So, we can go and count it out, but we can say that there's less than 200 parts of the skull base that you need to know to do most operations. And that's infinitely more in the brain. And we can't see the anatomy. So if you look here, is this a critical network or some irrelevant part of the brain? We don't know. We can have a few sulcal anatomy, but we also know that sulci really have only a vague relationship to function. So we have a lot bigger problem. So ultimately, when we work in the supratentorial brain, the challenge is putting anatomy into the operation, at least a concept of anatomy, when we have no visible anatomy. That's the key thing. So one of the things disconnections do is that they force you to think in terms of anatomy. So even though you don't see the salience network or you don't see the central executive network, still there, right? The brain knows what it's doing. You just don't see it because your eyes aren't designed for that. And so what we started to think about was, given what we know about the gross anatomy of networks and where they are, what is the safest way to make a cut in the brain? Okay, so we came up with a series of 8 basic disconnections. And we're going to go through these. Some of these we're going to cover. If you look at the first 4, we're going to really the first 3 and the insula one, we're going to cover that in the next part of the course. So we're going to talk about the medial frontal, lateral frontal disconnections, temporal disconnections, insular surgery, and how do we incorporate networks into that. But if you look at the parietal, occipital, and the parietal perculum to occipital lobe, there's also a different set of issues, mainly around the default mode network and the language system that we'll talk about in lecture 3. But basically, to take you through the thinking, you can see that the medial frontal disconnection has really 3 major boundaries. One's with the salience network in the posterior part, the DMN medially, and the language system of the neglect system laterally. Those are your boundaries in CEN. So they kind of make a U-shaped cut that you can take all the way down as far as you want. Now, these cuts show lobectomies. And sometimes lobectomies are the right answer, sometimes they're not. That's not what the point of here is to figure it out. It's that if you had to do a lobectomy, this is the entire cut you would need to do. And we talk a lot about this in the book, and we can go into more details on it. But I think one of the key points is that what in all of these do is they force you to think about networks and how to disconnect from them. We built this into a software. I'm going to use this software to show you where these networks actually live. And essentially, we automated it to where these disconnections are built into the software. So you basically just say, I'm doing the lateral frontal region, and it pulls that the objects out. So you can actually put it on image guides. That's QuickTone. That's our software, which is approved in multiple jurisdictions now, and people are using it around the world. And that was the concept, was could we just take the disconnections and put them into a software so that no one had to sit down and manually do that. And we could go into the details if anyone's interested in how we define networks and how we figured this out. But suffice to say, the FDA thought what we said was reasonable. So again, getting into this disconnection. So what you're looking at here, couple things. So I pointed out the medial frontal disconnection has cuts with the networks. Now, if you're looking at it from the top in the upper left image, it's a U-shaped disconnection. But look at the second image, the coronal image there. Notice that we're going around that little green area. That green area is the cingulate bundle. And right now, that may not be exactly obvious why we made a point of making sure that we veer and leave the cingulate gyrus there. But by the end of this lecture, I absolutely guarantee you'll understand why we do that. That's critical. You also notice that we save the orbital frontal region. That's not in there. Now, sometimes you remove the orbital frontal cortex because it has cancer in it. But why would we remove most of the frontal lobe all the way to the frontal pole in this disconnection, but leave the orbital frontal cortex? There are two basic reasons. The first thing you should think about is if I make a cut in the brain that disconnects a part of the brain from almost all of its neighbors, then I might as well remove it. It's not likely to being that functional. So for example, if I cut the entire temporal lobe down to the ventricle, then the temporal pole is not really connected to anything. It might be connected to, to the uncinate or something, but it's probably not really functional. It's not really getting all the information it needs. So why have a cancer recur there? But the orbital frontal cortex is different. We actually published a paper in JNS on this several years ago, and it basically connects entirely downwards and back through the IFOF. It doesn't really communicate as much to the frontal lobe. It does a little bit, but not much. And it's really important for judgment. It's actually what keeps people a civilized human being, particularly on the right side. And so if you don't have cancer in there, save it. So you can see that we make a cut that hooks and spares that. And that's a pretty radical disconnection. Now, what does that really look like in real life? So you have this tumor here. It's a large medial frontal tumor. And 10 years ago, how I would have removed this is to just remove this circumferentially, cell at a time, the way I was taught. But the reality is that that's inefficient, number one. Number two, most of the risk is at the back of the tumor. So why don't you do that while the image guidance is still accurate? Because as the case goes on, the image guidance will become less accurate. And also, it misses the point, right? The real point of this operation, most of this case is fairly straightforward. But here you have the default mode network. It's plastered on the medial side of the DMN. You have the central executive network, or CEN, plastered on the outside. And you have the sensory motor system in the back. So basically, you're making a cut there, and a cut there. 3 cuts. And you're going to follow that all the way down and keep it connected. Now, what people always say when you start talking about, saving function and things like this, they'll come around and say, well, aren't you leaving tumor behind? And the answer is, well, yeah, of course you're leaving tumor behind. That's the whole point of making a decision. But I'll say that everyone's always leaving tumor behind. That's number one. And number two, look at this resection. This is not a biopsy, right? We're not leaving huge amounts of tumor behind if you're doing it well. Just like when people say, I leave a little bit of tumor behind to save the facial nerve for an acoustic neuroma, it's the same thing. You're not leaving most of the tumor. There's no reason to do sloppy work. But if you look at that arrow, that tumor is in the basal forebrain and basal ganglia. So if you want to go after that, you can. I don't personally do that. And you see that immediately there's a little rind where the default mode network was. So it doesn't take a lot of work to keep the network still connected. So ultimately, it's a concept. And sometimes it's a concept that you have to break. So if you look at here on this really bad cancer, this is the salience network. Again, we're going to go into what these networks are, but it's wrapped around the tumor. It's plastered on it. The fibers are splayed. So should you save it? Well, that's a question. Can you save it? That's another question. We don't know the answer to that. What we do know is that it's difficult. And ultimately, as I pointed out earlier, sometimes you shouldn't save the network. Maybe here, this thing isn't doing anything, or some parts of it, like that green area on the left in the salience network, is still functional, but the pink area is not. These are things that we have to learn as we get more refinement. But the issue with it is the salience network is going to be very difficult to save. It's very compromised. And sometimes you might decide to sacrifice it. Sometimes the tumor is in the network. You can see here, this is the language system, and there's a tumor inside of it. This is glioblastoma also. Looks like a med, but it wasn't. So this is a bad problem. More importantly, now you can't always save it and shouldn't always save it, but you can have a frank discussion. You can decide things. And as we're going to talk about in some of the later lectures, you can actually do therapeutic rehab if you know that you're going to probably damage the language system removing this tumor. So it's a very different paradigm than we thought even 5 years ago, what's possible to do to treat a patient like this. So I've talked a lot about networks, and I'm going to basically go through it. We're going to go through this a couple of times in this course, because if you get nothing out, you need to know this, because this is actually how the brain's organized. So the word network arises from the fact that there are parts of the brain that are not next to each other that talk to each other very often because they're doing something together, like language or motor. And so if you look at their activity pattern, they're not identical, but they overlap a lot. And so if you take the brain and divide it into 7 networks, you basically get the sensory motor system, the visual, and the limbic system, and they talk to each other. So you look there, those are networks that aren't surprising. But you have the central executive network in yellow, the default mode network in red, the salience network in pink, and the dorsal attention network in green. These are the main axes of the brain. Now, if I go a little bit further and I break it even further, some of these networks divide. So if you look at the sensory motor, the face motor and leg motor are 2 different networks. So yes, they talk to each other, but they don't talk to each other a whole lot compared to the leg and arm talk to each other all the time. The visual system splits and the default mode network splits. Notice that the language system is basically part of the default mode network. But notice that there's a core DMN. So when people say DMN, and when we say it in our software, it means the core. And that looks like this thing on the right. So let's look at this diagram. You have in yellow, you see there's 3 parts to the DMN, and that's the yellow region. And notice that this network it basically is also in that little red thing on the left. So it's part of that DMN bigger, mega network. But you also have the language system in red. And that's because the DMN is kind of telling the language system what to do. It's part of thinking. And when you think to yourself, that's what the DMN does. Notice a few other things, though. Notice that the motor cortex is split in half. Notice that there's a brown network that has 4 parts. That's the central executive network. And if you look on the bottom, on the right side, the bottom image, the dark blue is the memory circuit of Papez. So again, that's the part where if you injure it, you start to get memory issues. You don't get it really from the cingulate above that. So the question is, when we start talking about networks, what do we mean? And this gets very, very confusing. So what I will tell you is that I spent years trying to get this really correct, because the literature is all over the place. People use the term for all sorts of things, and technically that all of it's correct. Any parts of the brain that fire more often than statistical chance are a network. In fact, if you strip it down, everything breaks down into 360 networks in the brain. But the answer is, when we talk about networks, we talk about the ones that seem to show up over and over again in the literature. They have clear evidence that destroying them is bad in most cases, and they really are reproducible. And we call those the core. And in general, don't cut through the core of those networks. Now, you have to look at it when we think about making the decision. If we say we're going to try to preserve the core of the networks, because if you say save the networks completely and use that thing on the left, you can't do surgery. Everything's part of a network. Everything's talking to at least one network. But not all of these networks are equal. And so what we have to think about is, number one, if we're going to back off of the surgery and do a less aggressive operation to save it, is it worth saving? If you're talking about central important cognitive function or leaving somebody mentally ill, that's a better trade than color naming or something that probably the patient could relearn. And the other thing is, should we save it? So if you have a network that's full of cancer, even if you save it, if you don't control the cancer, it's also going to take the network out. So we have to think, is that worth doing that? Sometimes sacrificing a network is the right answer, even though it will have a consequence. It's not that you always save networks. It's that you think about it and you don't accidentally destroy them because you don't know where they're at. Now, if you look at going through the anatomy here, how did we figure this out? Well, we took lots and lots of other people's papers and we did a meta-analysis to figure out where in the brain these are. You can see the names. It's not so important what the names of these regions are. If we had people willing to go through 12 hours of courses, I can teach you everything I know about these, which I've gone over these things for years. But that's not so much important as understanding the gross anatomy and what these networks are doing. So the default mode network core, which is what you're looking at, is a 3-part network. It has a large posterior cingulate part. It has an anterior cingulate medial frontal part. They're connected by the cingulum bundle that's in pink, and has a lateral parietal component. What's the most important is the medial portions, the ones that connect through cingulate. And if you had to think, what is the DMN basically doing? It's closest you have to a soul. If you really want to see where the soul is, when you think to yourself, this is where that's happening. So it does things like theory of mind, which is the idea that another person, you recognizing that another person has thoughts that are different than your own, internal thoughts of your own, imagination. More importantly, almost every mental illness that has ever been studied has a problem with how the DMN works. So it's safe to say that isn't true for the motor cortex or the visual system or these other things. Mental illness requires DMN issues. In fact, it's almost impossible to have Alzheimer's disease and have a normal DMN. It's actually one of the first networks to get hit. You don't know why, it just is. So it's very, very important for function. And if you look at its neighbor network, speech, notice that this is a little bit more sophisticated than what you're used to. And this is because, again, people have continued to study the language system and found out things that other parts of the broken word didn't figure out. It's not surprising that 2 guys in the 1870s didn't figure out everything about how language is processed in the human brain from autopsy studies. And so we've improved on it. So if you look, you have area 44 and 45, that's canonical Broca's. You have this area TE1P and PHT. That's the Wernicke's area. Note that if you go onto Google, you can find Wernicke's area in every shape and size possible. And so just doing that is a pretty good way to understand that up until very recently, we didn't really have an idea what Wernicke's area was or what it actually did. The best way to think about it is that those red dots are auditory cortex, and the area around that is where the meaning of words gets stored. So it's really like a library that tells you what words mean. And so ultimately, Broca's area uses this for various, phonemic relationships. There are 2 parietal regions that's probably best described as Geschwin's area. And we could go into details of what they do, but it's still a little bit complicated. One thing that's not as controversial is if you look at this area 55B, it sits in the back of the middle frontal gyrus, which actually I realized had a couple weeks ago that it has a name called Exner's area. But what it does is it's the auditory or the motor cortex for the larynx. So it controls the voice box. And we've had people have neurological deficits from the tumors located just there where they can't communicate. Also important to know that the SMA, even though it's not a language area per se, it's important for initiating language. And so we put it into the network as well. We also note that there are ways to look at how the middle temporal gyrus and Wernicke's area commutes with the temporal pole. We know that the temporal pole on the left side has language function. And we know that from studies of people who have semantic dementia, which is a dementing syndrome in the frontal temporal dementia, Pick's disease sort of spectrum. And people who have this have fluent speech, but don't have a good grasp on what words mean or semantic problems. And we know that it locates very strongly in the left temporal pole. So it's beyond doubt that the temporal pole is not non-eloquent. It just doesn't cause aphasia. It causes something else. Now, having said that, as I pointed out earlier, if you make a cut and cut the back of the temporal lobe, you've already taken that function out. And so for a lot of gliomas, it's not possible to save this. But the point of it is, there are some times where you can take approaches to go around that. But this gives us an idea about that really the hippocampus and the hippocampectomy in epilepsy cases is not so much of the problem. A lot of the problem is actually destroying this lateral system that goes in the cortex and communicates what words mean in verbal memory. Now, if you're going on from the DMN networks, so that all of those were, believe it or not, DMN networks, you have the salience network. Now, the salience network is older in evolution. So if you look at cats or rats, they don't really have much of a DMN. They kind of have the posterior cingulate part, but they don't have anything else. That really doesn't start to show up until primates and really in humans. So when you look at the salience network, rats have a fully formed salience network. And part of the reason is what the salience network is the decider. It's the go signal. And so, for example, when people have chronic pain, a lot of the problem for people with fibromyalgia is that their salience network is overactive. It basically, reacts to everything. You're aware of everything. And so there's a middle cingulate and an anterior insula network. I heard this described like as follows. The insula and the anterior superior parts of the insula are the interoceptive. They're the things that track what the heart's doing, what the stomach's doing, etc. So that's the internal world of your body. And then the decider, who needs to be made aware of what your body's doing, is the middle cingulate. That's what the cingulate gyrus does. It makes decisions, particularly the middle cingulate. And they're connected through the frontal ascending tract. You can see in the coronal section. The frontal ascending tract, that is basically what it does. It doesn't do much else other than hook up the salience network. And more importantly, this area SCEF is actually half of the SMA. So when we think about SMA syndrome, and we know that we recently published a paper showing that FAT injury causes SMA syndrome. And the SMA syndrome is a failure to initiate. So it's surprising the salience network has part of that. Now, when we start looking at the central executive network, it's actually a fairly complex network. Notice that it has very thin fibers. Okay, so that's the key thing. It takes a lot of work to see these things. It has a part in the frontal pole. So again, the area that we are always taught has no consequence. It does have a consequence, just this. This part tends to be more tolerant. That area 8C, it's right in the premotor area. That's the core of this network. It probably has a lot less tolerance, anecdotally. And then you see there's a parietal area, and there's actually also a temporal area. What the central executive network does is exactly what you think from something called executive. It makes decisions. It's part of working memory. It's part of multitasking. And so particularly on the right side is part of judgment. We've actually linked judgment to the central executive network. And so ultimately, it's the network that matures latest in life. It matures in your adolescent years. So it starts maturing around 12 and continues until 30. And what it does is it gets other parts of the brain to do complicated things to work together. And so that's what its basic function is. The dorsal attention network is the oldest network that isn't motor or vision. And what it does is it keeps the eyes and attention focused on a task. So you see it as the frontal eye fields. It has the interparietal sulcus. Now, the interparietal sulcus, if you're not familiar with the literature on it, the interparietal sulcus keeps a grid of where everything is in space. And so, not surprising that it talks to the frontal eye field. And then there's the lateral visual areas. There's three parts. That's the lateral occipital lobe. You see MT and MST for those of your students of neuroscience are critical higher level visual areas. And so what it does is it keeps you focused on a task. And if you don't focus on it, your IQ drops. So it actually has a cognitive consequence, even though it's doing mostly visual and attention. Now, it's also important as we go to the networks you're probably more familiar with, the sensory motor network. Think about it this: if you had the motor cortex and it was floating in space and you moved everything in front and behind, you're paralyzed, right? This motor cortex can't work without the rest of the brain. So there are numerous planning areas, and they talk in more complicated ways to each other and to the basal ganglia. And so in order to really have normal motor function, you might have someone who can lift an arm up and do this, but to really use your hand or be effective, you actually probably want to save as much of this as possible of the premotor areas. Now, again, if you look at the limbic system, again, notice that the orbital frontal region is part of the paralimbic system. It's part of emotional control, regulation, as well as the medial temporal lobe. As we know, they talk to the incident in a few other places. And so, again, this is what I was talking about earlier with the orbital frontal cortex sparing. Finally, the ventral attention network is a network that is only on the right side. I mean, there's a left ventral attention network, but it doesn't really do the same things. And it's likely the neglect system. So we've talked a lot about networks, talked about disconnections. Let's talk about trajectories really quick, and then I'll show you a few networks, and then we'll do more of this next time. So ultimately, when we plan a good trajectory, understand that no patient cares about white matter. Never had anybody say, thank you for saving IFOF. They care about function. And so not all little twigs and white matter are important. Some things are, and some things are redundant and can be compensated for. Cutting through a small amount of a network is worse than cutting through a large amount of a non-network. We know that just like cutting through 3 millimeters of midbrain is more dangerous than cutting through a centimeter of the frontal lobe, not all parts of the brain are equally tolerant. We'll talk a little bit about hubs. And the final thing about a good trajectory, when you think of all of it, is picking a trajectory that lets you work like this and not like this. Working back on yourself is always harder. And so planning your trajectory so that you work straight up and down. So let's talk about it. So shorter isn't always better. So if I go through the middle of Broca's area, how is that better than doing that? Okay, so we all kind of know that. And so when people have started talking about trajectories, and particularly when you talk about tube surgeries and things like this, but even before that, there was a concept that sulci going transsulcal was somehow better. And sometimes it is if you can take a little tiny approach, but not all sulci are good. Okay, so a sulcus is not the same thing as a fissure, right? So a fissure, you split the arachnoid, you get to the bottom, it's more arachnoid, and then everything opens up and you've cut no brain. It's beautiful, okay? The problem is that we've actually taken that analogy and tried to apply it to sulci. And so, while sometimes that is the right angle, sometimes what's at the bottom of your sulcus is the frontal eye field, or that area 55B, that's in the sulcus, or the interparietal areas. And these have networks or consequences. So it isn't that sulci are bad or good. It depends on what sulcus do you mean and what's in there. And so the only way we can make those decisions is to think in terms of what are these parts of the brain doing? Because a sulcus has equal amounts of cortex at the bottom of it as it does on the crown. So a gyrus is a gyrus. The brain doesn't care that that happens to be at the bottom of the sulcus. So ultimately, that sulcus is a bad one. And if you wanted to go take the brain and say, what are the sulci that I can tell you right now that are generally not good? Okay, so that's one of them. Interparietal, particularly anteriorly, not a good place to be. Going through the central sulcus. Don't have to explain that to you, but the motor and sensory cortex should probably talk to each other as much as possible. That's important for function. So there may be a reason to do it, but think long and hard. That shouldn't be your path of choice just because it's slightly shorter. The precentral sulcus behind the middle frontal gyrus. That's not a good place to be either. That's actually one of the worst places. In fact, we have pretty good data from various groups on that. Being in the superior temporal sulcus, especially posteriorly, that's Wernicke's area on one side and the ventral tension network on another. Going through Brodmann area 46, that's the actual place that people treat people for depression. So if you go through that, good chance you might cause more problems than going right next to it. Okay, so sometimes maybe you need to you could use the sulcus more posteriorly. Sometimes you pick somewhere else. Another one to think about is as you plan your approach and you're taking a trajectory, think about avoiding having, let's say that if you look here, this is the brain, bottom of the screen is like the neck in this diagram. And it's almost always easier to go straight up and down and try to work up under the temporal lobe. Anyone who's ever done that, particularly for glioma surgery, knows that's difficult. So while you may not always be able to do that, if you have a choice between two trajectories, pick the one that's straight up and down. Finally, people, if you go around and you see what people are talking about, every once in a while, somebody shows themselves taking out a CAV-mal or MET, or sometimes a glioma through some flashy approach, like coming in the sitting position through the tentorium or contralateral, these kind of things. And while in a very small number of cases, someone has a trophy scan to show off, my recommendation is in general, do things that you actually are comfortable doing that makes sense. So yes, it looks great when you can sneak a tumor out without cutting the brain, but most of the time you're not familiar with it. The angles are awkward. It's not clear where to stop, major blind spots. In general, essentially, oftentimes going and doing a much more complicated, unfamiliar operation so you can avoid cutting brain is suboptimal compared to going through a good part of the brain to get to the target. And so I've seen this happen over and over again where particularly junior people go to a course or whatever and they see some guy doing some flashy thing. And then what happens is the scan looks like a tiny little piece of the tumor is removed because they didn't know how far to go, right? And so remember that that person may also have a couple cases where that happened that they don't show you. So finally, let's talk about hubs. There's certain parts of the brain that essentially are more connected than everything else. We call those hubs. And we can calculate that. We can do this mathematically. So there are techniques you can look and say, how much is something connected to everything else? And it turns out that hubs, things that are highly connected, are different. They're more important. So let's say we take a DTI, we cut it up into regions. Do we calculate how many fibers go between every part of the brain and every other part of the brain? We get that thing on the right. That's called a graph. And that's like a big math equation. So we've reduced the brain to math. Then we can do experiments on it. And we can calculate who is the most connected part of the brain. So you can see here, there's different ways that these are connected. And if you look at that and say, who are the hubs? Because we know hubs, they use more energy, they express different genes, and they're really the fundamental cause of Alzheimer's disease. But who are the hubs? Well, it turns out if we were ranking an AVM using the Spetzler-Martin scale, these are the top 10 hubs across individuals, and those get you the point for eloquence. In fact, those probably should too. And so, because they're part of some pretty important parts of the brain. Bottom line is that hubs are eloquent parts of the brain. So the reason eloquent parts of the brain cause a problem is they're very connected parts of the brain, like the motor cortex. Lots of people want to talk to the motor cortex because it's communicating with the outside world, and so it's not tolerant. So we published this paper a couple of years ago, and what we were trying to get at was how often do people have hubs and parts of the brain that they don't know about? And the answer is 8%. So 8% of people have hubs in the frontal pole or some other part of the brain that we don't think is very important usually. And so as we know, some people, we do a tiny little operation and they tell us everything that's wrong, and we say, oh, let's do the private. Well, it could be we could have gone through a hub. So ultimately, a lot of the stuff we're talking about here, we put into a resource. You can see there's a Connectome Academy. We have it in English and in Chinese. And it gets into a lot more of the detail, provides some pretty simple understanding. But I think one of the things I'll just do as a kind of final bit while we're here, and then we're going to spend a lot more time doing this, is let's just go through some networks. So here we're going to use our software as teaching tool. And hopefully it runs smoothly. Okay. So what the software basically does, if you look on the left here, we have all of our networks. And probably most of you, if you've never heard of this before, had never seen most of these or read this, but you'll recognize where these words come from. And you can see that we generate an atlas that looks like this. Now it's going to keep pulling the tracks up, but we want to get started while we're waiting for this. And so if you look at, for example, the language system here, let's pull this out. And again, this is one you'll be familiar with. So we have Broca's area. The Wernicke's area, you see it's quite large. This, if you've ever done speech mapping, you know that naming extends quite a bit of ways from the canonical Wernicke's area in some people. We have the parietal region. We have the SMA. Again, it's still loading the tracks, but we won't wait for that. And this green area is 55B. So to show you where that actually lives in the real world, let's scroll the axial up here. So you can see middle frontal, this is superior frontal gyrus in the midline. Middle frontal gyrus, it's right here, right in front of the hand motor cortex, from the hand knob. Okay. Now, the networks, the three main control networks. So the first is central executive network. Again, it's still loading the tracks. You can see it sort of here. It's a 4-part network. Okay. You can see that the core, frontal pole, this is that 8C area. It's very big, as you see, part of Brodmann area 8.
Professor Mike?
Yes.
Sorry for interrupting you, but I think there is a lag in the screen. We couldn't see the screen moving.
Can you, oh, yeah. What, can you see this?
Not yet. I think it's the last slide of your presentation, isn't it?
Oh, I'm sorry. Yeah, let me, yeah, I shared the, how about this? Can you see this? Is that visible?
I think it's loading.
Now it's okay.
Yeah.
Okay, yeah, okay, good. Yeah, I shared just the slide.
Okay. Thank you.
Yep.
Would you please go back to the slides number 62? I think it's the academy.
Yeah, sure.
Yeah.
Actually, hold on. That's not the right one. Here you go. That one.
Yes.
So yeah, we've created a lot of resources because we recognize that this is new for almost everybody. We really are bringing something cutting edge into the world. But if you look here, you have the frontal. So this is central executive network again. You have the frontal pole. This is from left to right. 8C is this pink guy. You have the parietal region. Now remember, sometimes these fibers aren't very thick. And then you have this little part of the arcuate that goes to one temporal area. Turns out this temporal area is very important in emotional regulation. And you can see we have it on the other side there. Okay. Going to default mode network. Now, if you remember what I said earlier, it's a 3-part network. Now let's just go to the axial because I think it makes that easier. So you can almost always recognize it. It's kind of got these two lateral parietal regions, posterior cingulate, anterior cingulate. Now, if we look here in the midline in the sagittal, you see there's the lateral parietal. Notice this is like angular gyrus, so it's pretty far back. It's not the supramarginal region when I say lateral parietal. And then you can see as we go towards the midline, you see there's the posterior cingulate in purple, the anterior cingulate, and most of the cingulum bundle is actually doing this. That's what the cingulum does. Now, if we come off midline a little bit more, you see how that extends down into the hippocampus. So the parahippocampal regions also talk to the DMN. This is that memory circuit. So the upper part is it's the mentation, thinking to yourself, and the lower part's memory. You can imagine why they need to talk to each other. But you can see that all along here, there's no exception to this except for maybe the genu. If you're in the corpus callosum, the DMN is right next to you. It's 100%. So it gives us a real understanding of why butterfly gliomas hurt people if you don't do them correctly. Now, the third network is the salients. So let's zoom in a little bit. So this is in the sagittal view. So you see middle cingulate and then part of SMA. And then we come out here. Let's see. Yep. There's frontal ascending tract. And then there's the anterior insula. Now, notice it's not the whole insula. It's just this upper corner here. So a lot of times insular tumors push this up. And that's part of the reason why we don't, a lot of times you can remove them underneath it. But if you just keep going to try to perfect that, or you go really transopercular, you can cause more problems than you do in the insula itself. Looking at this on the sagittal, it looks, or the coronal, sorry. So you see there's the anterior insula and, sorry, the middle cingulate and anterior insula. And then that little orthogonal tract is the frontal ascending tract. Now, notice that it's connecting these two areas because we have both of them on. So it's possible to only show one side if you wish. But the bottom line is that's the salience network. Now, notice that if you think about it, if you go into that medial frontal disconnection that I had earlier, let's come up here, up. So that forms the back wall, right? So that's that back cut is with the FAT and salience network. Okay. Now you see that depending on angle that you look at, there's a lot of frontal lobe in front of that, but that's what you're really trying to do is keep all this stuff connected to itself. Now we missed the language system. Let's just go back to that really quick. So obviously the view we're used to is this one. And so let's come off to the left side. So there's the Wernicke area. Notice it's pretty large. It varies in people, but in short, not all of this is, if you injure it, you're going to not be able to talk. That's just not really how language works. This part of the brain just thinks about what words mean. It kind of has a library of terms. And then you can see these green guys here are Broca's area. As we go further to show you where 55B is, which I talked about, that's the motor cortex for larynx. We go all the way to the top. There's the arcuate. And we get to the top. See that green thing? Right there, that tiny little guy who's sitting down in there. Let me just zoom in. That thing right there. So this is the hand knob. Right in front of it. That's 55B. That's the motor cortex of the larynx. We didn't even know that there was a language area in that sulcus until very recently. So finally, I'll go to one more network. Now, I'm going through this quickly. Remember, we have 5 weeks, so we don't need to get it all right the first time. So we're going to repeat a lot of this. But if you go to the dorsal attention network, kind of has this 3-part sort of thing. So that's the motor cortex. So this is frontal eye field. Now 55B and frontal eye field are tucked into each other like this. In fact, they're almost in the same area. These little dots are down in the interparietal sulcus. So again, not the front of the sulcus, not a good place to be if you have a choice of what path. You can see there they are. Now, one thing I tell everyone too is if you have someone who's paralyzed and you think that the motor and there's a tumor or lesion in the motor cortex that you can't make them worse, just go below the sulcus and you can destroy one more network for them. And you can see that finally there's this part here in the lateral visual system. So 3-part network, 1, 2, 3. So we're going to go into more details. We'll go through some cases. We'll review this next time. But I think this is a good start to kind of give you an idea where we're going with this. And let me see if we'll go through some questions.
Okay, thank you, Mike. Very informative presentation. I'm interested how long it would take to do the examination of MRI for determining how this kind of very complex networks.
So the software does everything. So essentially, it's a roughly, if you're doing DTI with 30 directions and a T1, so that's about 20 minutes, depending on your scanner. Maybe you can get it down to 15, something like that. The software does all the processing in about an hour. We can probably get that lower, but we haven't engineered it for that yet. And then looking at it, once you get good at it, it takes a couple minutes. So there's no hand processing anymore. We eliminated that with the software. The next question, the challenge now is not, can you get this on your image guidance? We do that all the time. It's what do we do with the information? How do we make good decisions with it? But getting networks on MRI, out of an MRI is now it's a commodity. You don't need any expertise at all to do it.
Okay, thank you.
Okay, Professor Mike, thank you for this insightful lecture about the connectivities. So, as you know, there is a usual debate between functional surgeons regarding, especially regarding the insular glioma, whether to go transsylvian or transcortical. So, in your point of view, what is the best approach for that?
Well, here's what I would say. In most cases, the tumor's made that decision for you because there are very few insular gliomas that are only in the insula. Now, so if it's in the temporal lobe or the frontal lobe or the hippocampus or whatever, that makes it easy because if it's already filling the temporal lobe, then obviously you're not going transsylvian for that if you actually want to get a good resection. Now, let's say it's just in the insula because that's where you actually are comparing apples to oranges. The answer obviously is whatever you're most comfortable with, but my view on it is the following. And actually, let me just go share a screen and I'll show it to you. But it really just comes down to geometry at the end of the day. So let's go to here and I'm going to turn off a few things. Actually, why don't we just make the language system? Okay. So let's zoom in on this. And there's a challenge, right? The challenge is that the operculum is far lower and higher, particularly higher than you think. And the second thing about it is that really you're standing up at the top of the screen and the patient's head's down here. So you're always, when you go up here, you're always working basically back on yourself. So without removing an opercular cortex, this is difficult, even with a very wide sylvian fissure split. And there are some tumors that are bulging out of the fissure when you start. So in most cases, I would say a good 60% of insular gliomas have a temporal component. I just pulling that off the top of my head, but it's a large percentage. But if you just are in the insula, I look at it and say, it's actually better in most cases to remove at least the anterior STG if you can from a functional standpoint, which you usually can, and see the IFOF, because that's where the IFOF is sitting, see the anatomy, what you're doing, than it is to work kind of upside down blindly to just because you want to save brain. Because the reality is if you remove the insula, a lot of this operculum is actually connected to the insula. So what are you really saving, right? if you've disconnected it, you probably might as well just take it out. So having said that, if someone told me they remove everything through the insula transsylvian, yeah, nothing wrong with it. I just, for me, I find it a lot harder to do a transsylvian and get a resection that I'm happy about. And so if you're comfortable with function, you know that the anterior SCG rarely has, there's no real major networks that we know of. It doesn't seem to have a whole lot of really profound consequences. And really, if you feel comfortable defining network mapping and identifying that where you have to stop your cut, then it's really rare that that's what causes the problem. There's a final thing that I think is really important to grasp. I wrote a paper about this a few years ago, and they made me, the reviewers made me call it the artery of aphasia, but I called it the artery of death. And there is an artery that does this, okay? It comes off the back of the fissure and does that. And on the left side, it's the blood supply to Wernicke's area. Now, if you're in any of the rest of the MCA vessels and you're removing it and you get a little hole in it or you manipulate them, they tolerate it fine, okay? As long as you don't cauterize them or twist them or something. But this one artery, all you have to do is work underneath it too hard or pull on it and it can get I think it's a focal dissection or something, but I've seen it happen to myself. I've seen it happen to other people too, for good people. And so one of the challenges when you're trying to do all this transsylvian is you're going to end up having this artery exposed. And I find that I want to not even touch that artery because if you injure it, it wipes out Wernicke's area. So I kind of view, get some space, make sure you can see what you're doing. Don't touch this artery. And, you know, I find that most of the time I can do that better with a transopercular approach. But I had a case one time where I could not remove anything in the STG or superior operculum, and that was the only option I had. So I took it out transinsular. So it's good if you know how to do both.
Yeah, thank you so much. You really made white matter anatomy sound more interesting to me.
Yes, Michael.
Actually, I think we have a question. Okay.
The real operation actually is more complicated than the networks of the neural networks, but also the vessel networks. So can this, if MRI can merge with the DSA results?
I'm sure it's possible to do it. It basically comes off as DICOM, so it can merge with anything to some extent. All that comes out is it gives you an overlay of the tracks and networks as one object. So there's a overlay for the language system, for example. So if you've had the T1, if you brought the DSA in and fused it to the T1, it should work. It would take a little bit of technical work to work how to do it, but there's no reason why it wouldn't be able to.
Okay, thank you.
I think there is a question in the Q&A box asking about how can they contact you about the software.
John.
I'm sorry?
I noticed Professor Jizhong Zhao at the audience list. Would you please invite him to the panelist?
Sure. What's the name again, Dr. Ben?
Jizhong Zhao.
Okay. I'll try to find it here. Okay. I'll keep looking for him.
So yeah, what someone asked about the software, it's available in the US, China, in India, and right now we're to some extent in the European Union. So we have teams in all those places that people are interested.
Okay, another debate is that whether the stroke of Broca's area could cause a long-term speech deficit.
It's a challenging question because what we have to separate out first is speech versus language are not exactly the same thing. Okay. And so think about it this way. We have a term called apraxia. So not being able to move your hand is a motor problem. Not being able to use a hammer is apraxia. Okay. So apraxia is I can do the movement, but I can't plan it out. The cognitive control of motor is incorrect. So there's a cognitive control of face motor, and that's language. So talking and saying words and things is speech, and that's an important, very complex motor function. But making sure that that speech makes sense is a language function. So when you say that the temporal lobe has a language function, it doesn't have a speech function. We don't cause aphasia. So the patient will look fine until you do a test or you see them function in the real world, or you talk to the family and they say, well, what he's saying, he's having problems with his speech, is what they'll usually say. And you'll talk to them and you have to do the test and he'll do fine, right? Because his speech is fine, but his cognitive language is incorrect. And so we have to separate those words out. Broca's area is a language area. It's a cognitive area. It's right next to the speech motor control area. It's not surprising because it's the final output. So when people say I can remove Broca's area and the patient isn't aphasic, what they're saying is, well, no kidding, it's not supposed to be that. It's a language area. It's a cognitive area. Now, what's interesting about cognitive function is that when there's tumors, the brain probably can figure out other ways for different parts of the brain to communicate if you give it enough time. Whereas the motor cortex does that a lot less because there's only one way it can connect to the spinal cord. There's just no other option. And so we can get away sometimes with removing a low-grade tumor in Broca's area. But remember that in a normal individual, if you remove Broca's area, even if they can continue to communicate, you're going to they're not going to be normal speech. And it can be in ways that are very subtle that you don't pick up in the clinic, but they know it. Now, again, it just depends what you're treating. Now, the problem with it is it's really hard to cause a stroke in the speech arrest site and not in Broca's area. They're right next to each other. And so there just isn't a lot of really detailed work on that. But if you've done intraoperative mapping, you know that the speech arrest site is usually right in front of or the front boundary of the face motor cortex. And you don't get that by stimulating Brodmann area 44. You don't get something obvious. And that's why I show is that I would claim it's the intraoperative testing that we do that shows some things that are obvious in the operating room isn't always the only thing, because some things don't really turn off when you stimulate the brain, but they cause problems.
Okay, thank you. So if you can call Broca's area a language area, do you think there is anatomical variations between people who speak different language in Broca's area?
Well, yeah, we've done, when I was at UCSF and to some extent in the US, though or in Oklahoma, we have a lot less of that. I have been part of speech mapping in 3 or 4 Indian languages, Chinese multiple times, Vietnamese several times, and Spanish many, many times. So I've mapped a couple different languages and probably a few others that I don't remember. And what you find is that there will be a site for the primary language and a slightly smaller site right next to it for the secondary language. So you're storing them in the same location. It's not random. Interestingly, there was a case that was done awake in a sign language patient, and it turned out that the language areas were next to the hand and not the face. That was interesting. But having said that, probably area 44, which is what we call Broca's area, is kind of always there. It's a cognitive area. And so this arrest site, the speech arrest site, was the motor hand arrest site. It's the motor planning area for the hand. So it's like the dorsal premotor or ventral premotor area or whatever. And so, yeah, where that site gets placed is going to be based on what you use to communicate. But the cognitive system that you do it from is going to be kind of the same. So what we know is that if you take individuals and you look at their cortical regions and networks, they're over on the average, every average cohort is the same. And you and I will have the same basic region, so everyone has a DMN. But sometimes you'll have a little island of CEN in the middle of it where most people have a DMN. That's what makes us unique, is a few voxels. It's not most of the networks. And so Broca's area in a normal person without the disease is generally going to be about the same place, at least in all right-handed people.
Okay, thank you. Is there any question, I think?
Michael, I think there's a lot of specialists, like a musician who play violin, and if he want to protect his special technique, is it possible to do the pre-operative examination for this kind of network?
Well, here's what you have to think about. So it's an interesting question, and it's actually I can use this to explain some things. So think about networks like this. There's not going to be a violin network in the traditional sense. So if I do a resting state fMRI, I'm not going to find a network that he has that's violin. But when we talk about complex functions, so not something that isn't really simple, like thinking to yourself or carrying out a math problem, something in the lab. We're talking about real world things like doing your job or violin or something like this. So we'll use violin as an example. In order to do that function, you have to have visual, auditory, motor, planning, attention networks, some higher cognitive memory. All these things have to be working together, right? And it isn't every part of every one of those networks. It's certain parts of those networks working in different combinations. So the way I describe cognition is it's like an orchestra. The DMN would be the strings, like the violin and the viola, and the percussion would be the CN, and the salience network would be the flutes and woodwinds. By themselves, they can do some things, but together they make a noise that can't be made by any one of them by themselves. And it's very rare in an orchestra that everyone's playing at the same time, right? So some guys play together in certain parts and some guys play together others, and they're not always in sync. And what comes out of that is the symphony, right? And so in order to handle the violin guy, first you have to maintain his motor function. You have to maintain, but also if he doesn't have attention, he's not going to be able to play at the same level. If he doesn't have, ability to multitask, that's going to get a lot harder. So not cutting through the core networks is a start. But then, of course, there probably are a few parts of the brain that are between the networks that are just necessary for violin that we don't understand. We don't understand how really complex functions happen. We know a lot more than we did 5 years ago. So we know we have maps of, like, if I look at a certain thing and I look at what networks and parcels are firing, there's some papers that show that you can predict what emotion someone has at that moment. So we're a lot closer to that, but we haven't worked out all the code. What we can say, though, is if you cut through the DMN and they can't concentrate, focus, think, or have a coherent thought, it's probably clear that they won't play violin. If you paralyze them, they won't play violin either. And so what you say is that, let's say, for example, we don't know exactly how you do it, but we have some ideas. We know some things that are important, attention, for example. And we want to leave this guy able to play violin. Well, it's ultimately what we have to say is, let's keep his functions, his core networks, as functional as possible. And while he might initially struggle, he probably has enough groundwork, enough of the material to relearn it and get back to where he was. Whereas if you take the core functions away, that's a lot less likely because he just doesn't have the substrate. Now, we don't know that's the best strategy, but it makes a lot of sense that it'd probably be better than, cutting through the salience network and causing an SMA syndrome is going to probably hurt his violin a lot more than anything else we can do.
Okay, thank you.
I think there is another question there in the Q&A. They ask about which part of the brain to get involved to HV aphasia.
So what is HV aphasia?
I don't know.
To have aphasia. Yeah, that's a complicated question, but in essence, destroying the speech system is the more consistent way. Now, remember that some parts play multiple roles, like Wernicke's area is involved in all of them. But the bottom line is, in general, the language system is probably your best place because it has all the at least in our model, has all the architecture for speech and language into one network. And that seems to do pretty well. If you keep the SMA, 55B, Wernicke's and Broca's area all connected to each other, you usually don't get any very bad problems. Having said that, do you get, remember, you don't have to be aphasic to have abnormal language function. So again, if you doubt it, watch a video on semantic dementia. It's actually very informative. And so if you talk to someone who has semantic dementia and you ask them, do pigs drive cars? They say, well, maybe if they have to get somewhere, they might. Well, that means they don't know what pigs and cars mean, right? Even though they can communicate, their speech is fluent, they don't know what the words really mean. And that's a lack of content. They just don't, they're not aware of it a lot of times. And so we don't cause that as purely as the disease does. But if you remove the temporal lobe, it's crystal clear from epilepsy literature that a good portion of people, particularly on the dominant or left side, have trouble with verbal memory after that. It's just the consequences of an intertemporal lobectomy. Now, depends on what you're trading that for. And in general, I think that if you're talking about a glioblastoma there, or it's a cure for your epilepsy that's debilitating, you might be a worthwhile trade. But it has a consequence. So it doesn't mean that we can always avoid that. But what we want to do is make sure that we don't just think, oh, you can just go right through, there's no consequence. That's not true. It's the consequences are maybe acceptable in certain circumstances. I don't know if that answered the question, but to really do that justice, we could almost have a whole course.
Okay, thank you. Shalash, do you have any other questions?
Okay, thank you, Michael. And today, actually, it's eve for the Chinese National Day. Thank you very much. Yeah,
I'm glad I rolled out National Day in style.
That's the holiday.
Yeah, yeah. Tonight, still have around 300 people attend listen to your presentation. Thank you.
Great.
Mm-hmm.
Very good. Any closing comments or questions for Michael? Okay, thanks everyone for helping Ben Muhammad. And next week, the same time, same channel, part 2 of the series, correct, Mike?
I think so, Ben. With National Day, given this is
coming. Oh, is that National Day next week, Ben?
It's okay. It's okay.
No, we'll discuss it. We'll discuss it.
Yeah.
Okay.
Yeah,
okay.
I want to make sure if everyone's going to be there, we can do it. So I want to make sure that
we'll communicate and let the public know also. So stick around and network. Thank you, everybody.
Right,
Michael, you mentioned that there's an academy. I noticed a company called there's a Chinese company. Is it possible?
That's our company.
Yeah. Is there any stuff that it's very familiar for your presentation, and maybe he or she can translate it into Chinese, and so we can do the bi-language.
Yeah, there's actually a couple of them are on the video with us.
Okay, so maybe you can let them contact us.
Yeah, sure.
Okay, very good. Stick around to network. Thank you.
Thanks, everyone.